Well, good morning, everyone. That was a really nice introduction. Most embarrassing. Thank you. Okay, so we're going to be talking today. Title of our talk is Sexuality, HIV Prevention, and Female Genital Cutting, Perspectives from Somali Women Living in the U.S. And as you can see from our slide, it's a collaboration between two state universities in Minnesota and a Somali-based community organization, Midwest Community Development. Oops. There we go. And we won't say any more about us since you're tired of hearing about us at this point. But there we are. We took a lot of time on picking these photos. Okay, here's the rest of our team. We call our research group, the Somali Women's Initiative for Sexual Health. We call it SWISH. I'm always up for coming up with catchy acronyms that mean something. And I guess I just want to point out Amira Ahmed. Whoops, that's not what I need to do. There we go. Amira Ahmed is the director and founder of the community-based organization, and she was integral in helping us design and carry out this study. And Fatah was our project coordinator, and Shonda Hunt, Fatah was our interviewer, and recruiter. Fatah and Shonda was our project coordinator. And then you can see the other people who were involved in the project. Okay, why don't I start by talking about our study goals? Okay, one of the goals was to collect information on HIV STD testing and prevention among Somali women in Minnesota. We wanted to particularly focus on collecting sensitive information on sensitive sexual topics related to HIV STD transmission and testing. And as Walter noted, as a sex therapist researcher, we feel that any intervention around HIV prevention needs to really understand the sexual culture of the various communities that we work in, so we think that's very important. And then finally, we wanted to collect information regarding female genital cutting or female circumcision or female genital mutilation, whichever term you prefer. And actually, we had a lot of debate about which term to use. And I think we came up with female genital cutting as the most descriptive, appropriate, and respectful. I think we felt female circumcision didn't quite characterize the extent of the cutting that was done in some cases, and we felt that female genital mutilation also didn't really accurately describe, because some of the cutting is very minor. It's just like a piercing or a scraping or a stabbing. So we really felt the cutting, the female genital cutting, was a better term to use. In the literature, you'll see that female genital cutting has been hypothesized to be related to HIV. And nobody really knows exactly how. For instance, we don't know how the practice of female genital cutting affects the ease, comfort, and use of male and female condoms, and also whether they're likely to be used or not. Female genital cutting is universal in Somalia, or practically universal, with the majority of women undergoing the more extreme form, which is called type 3. It's been characterized by the World Health Association organization. And that includes a narrowing of the vaginal opening through the creation of a covering seal formed by cutting and repositioning both the inner or outer labia. And that can happen with or without the removal of the clitoris. Often it happens with removal of the clitoris. So it's a very extensive and very, you see where the term mutilation came from. Some people feel it's a very mutilating type of, I won't call it surgery, it's not really surgery, cutting. The World Health Organization in 2008 estimated that 98% of females between the ages of 15 and 49 living in Somalia have undergone female genital mutilation. So it's very widespread in Somalia. And it was funny, I was on the plane yesterday, was reading the New York Times, I always get to do that, and there was an actual article yesterday talking about, and we've heard of this happening, of girls being taken, because it's the cutting is illegal in the US, it's also illegal in Europe. And, but sometimes families take their girls back to Africa or somewhere else to have the cutting done. And actually they were talking about in this article that this is happening. And in the article they also said that Somalia, I didn't realize this, actually has the highest rate of female genital cutting in the world. So that was number one. Okay, let me give you a little background on Somali refugees. I was really struck by this figure. 1/3 of the population of Somalia is displaced over the past 2 or 3 decades, and the UN Human Rights Council said it was one of the worst humanitarian crises in the world. So I was sort of trying to kind of apply that to the US and think about what that would be like if that happened here. And it's like displacing 105 million people in this country. That would be 1/3 of our population. So it would be like taking the 4 states with the largest populations and just like either having them leave the country or move somewhere in the country. So that would be California, Texas, New York, and Florida. So all the populations of all those states got displaced. It's really mind-boggling. Somalian refugees are the largest African group to enter the US. And the majority have settled in Minnesota, California, Georgia, and Washington, D.C., with the largest population in the country in Minnesota for some reason. Somewhere it's upwards of 36,000 Somalian. And the majority of Somali refugees identify as Sunni Muslims. So when as Walter said, I grew up on Frockway, and when I threw I really did this, my steamer trunk on the train and headed west, I had this New Yorker, I don't know if you guys have ever seen this New Yorker's map of the US. So, you know, there's like New York, and then there might be Boston, I guess. California. And then there's California, and maybe and Japan. Florida and Japan. Yeah. So anyway, I know that everyone here is a lot more informed than I was, but I'm going to show you where Minnesota is anyway, just a reminder. And I've been out there for a number of years, and us Minnesotans are proud of our state. We're proud of Hubert Humphrey. We're proud of Walter Mondale. Prince is out there, comes from there. We were the first state to protect transgender rights in 1993, passed the first law. And we also have the dubious distinction of being the only state to elect a professional wrestler to governor. And you maybe remember Jesse the Body Ventura. Well, he was unfortunately our governor for a full term. And as you can imagine, it was not a happy time for many of us. But anyway, we're in the heart of the upper Midwest, born in Canada, and some would say it's an unlikely place for many Somalis to end up. This is Somalia, on the east coast of Africa, and it's considered to be in sub-Saharan Africa, which is really everything south of these countries, and this is where the HIV crisis resides. And Somalia is also considered part of the Arab world. And the body of water is the Arabian Sea. So just some facts. They're Minneapolis to Mogadishu, 8,000 miles apart, while their July temperatures are very similar. As you can see, their January temperatures are almost 100 degrees different. So it's been an adjustment. I think that weather has been an adjustment for many of the Somalis who come. Okay, so why did we choose to study HIV in the female African-born community? Primarily is because HIV rates among African-born immigrants or refugees to this country are very, very high. Probably because many of them are infected when they come here, is what we think. So you can see if you look at rates, I compared it to African born immigrant rates with African American rates, and you can see they're about almost 1.5 times as much. So a lot of people don't know that. And you know, everyone knows, a lot of people know that African Americans clearly have the highest rates of HIV in this country, and I just have that figure there to say that. But what's interesting is that surveillance methods in most states do not separate African-born from African-American rates. And so those two rates are often kind of mushed in together. Unlike the US, the African-born epidemic is mostly female and heterosexual. And another problem that applies particularly to Somalis is that they typically get tested for HIV late in the disease, obviously leading to higher death rates and higher infectivity. And I'm going to turn it over to Jennifer.
Okay, so I'm going to talk about what we did in the study, starting with recruitment. So we had, as you mentioned, Fatah was our main recruiter and interviewer, although we had, Amira did some of our recruiting as well. And they kind of, through a number of different places, I'm just going to go down. Fatah went to, in Minneapolis, we have 2 very large Somali malls. And so Fatah would kind of hang out at the mall and talk to women. There's different restaurants and coffee shops. So part of it was just talking to people and saying, you know, this is what we're doing. Amira runs some parenting education programs for Somali women, and so she did some of our recruitment through those. And then there was word of mouth as well. And kind of, we tried to follow a community-based research method, so getting out into the community, and especially because of our topic, helping people feel comfortable that, you know, we weren't there to stir up trouble. Although we still got that reputation a little bit. So we tried to, you know, kind of communicate with a number of people, let people know why we were doing what we were doing. And that included that before Fatah started any interview, she would meet with people informally and just talk, you know, we were talking maybe like a half an hour of just get to know you, kind of, not an interview, but a conversation before she started the interview. Okay. We put together our own questionnaire. For the most part, it was our own. And it was a development between the researchers and a number of Somali women that were on the project. And we had a 14-member advisory board. And the community advisory board was made of HIV workers as well as community members. And so before we started the interview process, we brought, these are the questions that we're going to ask to the board. There was lots of conversation, lots of angry conversation at times about what is appropriate. And our board members didn't always agree with one another. So there were, you know, one of the moments that stands out is a woman who was, you know, you can't ask about lesbians, and she got up and started saying, I'm not going to be on this project, and that kind of thing, and other women within the same community saying, you can't not ask. And so it was really useful to have the advisory board. They also gave us some feedback on, you know, ask the wording of questions and those kinds of things to make them more appropriate. So we had both English and Somali versions of the interview, and so people used the consent form that was appropriate to them. And the interviews lasted 30 to 60 minutes. We audio recorded them, and which people were okay with. And the interviews happened either in homes or agencies. So we had 30 interviews, so this was a pilot project. And that 22 chose to be interviewed in Somali and 8 in English. And we expected, Fatah said many times, you know, you cannot answer a question. We expected people to not answer questions more than they did. Almost almost all of the time people answered questions, although sometimes they did pray before they answered the question because they were a little shocked at some of the things. Yeah, that was usually the anal intercourse question. Okay, so I'm not going to read all of these, but as Bean was talking about, this started as an HIV project, but we really asked about a wide variety of questions. There's next to nothing written about Somali customs and sexuality, and so we wanted to kind of have a better idea of the culture as a whole. And so questions were about broadly sexuality as well as specific questions. And I wanted to point to number 4 that when talking to women from the Somali community, we use the word circumcision, and the rest of, in our publications, we use female genital cutting. There is some research out there that says that Somali women would prefer the use of the word circumcision. It just felt more respectful. Okay, translation. This was our biggest learning curve. So we initially tried to hire women that could do the translations for us. So we had the audio recording, and then they translated the audio. For example, we got a small grant from my university to hire a student. That was kind of a disaster. So a couple of the women just, it was taking a really, really, really long time. And so we ended up going with a professional interpreting group. So that's just a little research methods tip if any of you haven't done translations in the past and would like to in the future. That worked extremely much better than trying to hire our own person and relying, we can't test somebody's Somali. So we had to rely on Amira to do that, and it just took a while. So, and then we had a college student, a Somali college nursing student, who back translated all of the transcripts so that we could see, and that they did rather well, and we didn't have to change much when we back translated. We used a professional transcription service, and then the data analysis was done. There's some qualitative data analysis done in vivo, quantitative, and SPSS. And the quantitative, we only have 30 people, so this is not sophisticated stats. It was pretty much descriptive. Okay, so we did 4 pilot interviews before we did the 30 participants, and so this is the demographics of our group. So the average age was around 32, but we purposely chose women of childbearing age. And let's see, most were married, so 17 of the women were married and 4 were divorced or separated. All of them, not all of them, most had children, so let's see, 18 had children, and 20 worked outside of the home. Some of the women that didn't work were students. So most were on some form of public assistance, which gave us an idea of income. And I don't know if we said that everyone in our study was born out of the country. So 28 of the women were born in Somalia, and 2 were Somali ethnicity but born in Ethiopia. So the average time for the women in our sample were 12 years, average time of length in the US. And the education was all over the place. We had several women that had no schooling, no formal schooling whatsoever. And we had one woman who was earning her master's degree. So it just kind of ranged all over. And everyone was Muslim, and everyone endorsed that they were heterosexual. So I wanted to include, in case you weren't that familiar with refugee stories, I wanted to include sort of what is the typical life to get to the US from Somalia. And so here's a quote from one of our, and I'm not gonna say the Somali part, just read the English. I was a refugee and I left Somalia because of the problems that I have been through. I'm an adult and men came to me and tried to rape me, but at the time I didn't get raped. We had a robbery at the night and my children and I had problems and we struggled. All praise due to Allah. We came to the refugee camp. We stayed in the camp and we got this process, and America brought us in here. God bless America. Now we have a beautiful life. This was a very typical story. Some people gave more details. So I think when they did, they usually talked about going to 2 to 4 refugee camps. So it's an arduous process. And there goes my name tag. So, and oftentimes they come directly to Minnesota. Thank you. They come directly to Minnesota, sometimes through other states as well. So Fatah asked, why did you come to the U.S.? And just, this is an open-ended question, not a forced choice question. So as you can see, I actually would expect this to be higher. 20 women said that they came because of the war. So they came to find peace and safety. And another 10 said education. So they could endorse more than one. And one came as a baby, so she doesn't remember. Or she didn't make the choice, really. Okay. I'll leave that there.
So we obviously want to present the results of our study. In terms of getting testing for HIV, you can see that a large percentage of people were tested, 86% of them. None of them self-reported being HIV positive. And here are the reasons they gave for testing. Most women, as you can see here, did not state a concern about disease as a reason for testing. And many of them expressed the belief that the Islam religion protects them from disease, so testing isn't needed. And you can see that most of them got tested kind of as a part of, wasn't mostly self-initiated as a result of immigration. In order to get into this country, most people end up being tested. I was surprised it wasn't higher. Maybe it was because the women didn't have a lot of knowledge about the testing. Pregnancy was another time, annual exam. Several women made statements such as, I was tested for everything, or I don't know what I was tested for, and other statements sort of indicating a lack of understanding about what HIV testing really entails. We developed just a brief HIV knowledge question based on some 2 items from the CDC and Domenighetti. And as you can see here, I would say that they had probably a moderate knowledge about HIV, how HIV/AIDS is transmitted, but clearly there's room for improvement. I was they knew that sharing a glass, you couldn't get HIV by doing that or by coughing, but the swimming pool was kind of interesting, I thought, with a third of them really thinking you would catch it by swimming, which I thought. And there is some research with a larger Somali sample in Europe that found lower levels of HIV knowledge among Somalis than among other African and immigrant populations, and especially among Somali women, lower levels of knowledge when compared to men, Somali men. We asked them about condom use. Wouldn't be an HIV study without asking about condom use, right? And you can see here that 58% of them had ever used them, but you can see that very few are currently using them, only 15%. And then when you look at why they were using condoms, you can see that pregnancy prevention was almost 50% said for that reason. But they did, HIV was mentioned, and a third of them talked about HIV and or pregnancy prevention. We were obviously concerned about their attitudes toward condom use, and we were pleasantly surprised by these results. So the majority were not opposed to their use. And in kind of reading about Islamic religious prohibitions, there really isn't a prohibition against condom use in Islam. And I'm going to just quote this: scholars interpret the Prophet's approval of coitus interruptus to indicate that all forms of contraception are acceptable, including condom use, because pleasure, not reproduction, is the primary purpose of sexual intercourse. And we'll talk more about that, but many of the women talked about how it really is important for a husband to pleasure and give pleasure to his wife, and that sexual pleasure is important, unlike maybe some other religions. We obviously were thinking about taking our pilot results, and we're in sort of communication with NICHD to try to get a larger grant based on these results. And one of the things we're interested in is how are we going to educate this population about HIV. So we asked questions about HIV education. And even though there's this culture of privacy, many of the women preferred to attend an HIV class. That was the way that they wanted to get information about HIV. And very interesting to us, almost all said they would attend a class with Somali women, not so surprising maybe, but almost 90% said they would be in a room with men talking about sex, which was a surprise, I think, to us and a lot of the men in the room. Okay, so as Jennifer noted, we had 17 women who were married of the 30, and all of them reported being sexually active and engaging in vaginal intercourse. None of the unmarried women reported engaging in sexual intercourse, and 2 women who were dating reported kissing only. It is a sexually conservative culture. The majority of all women, even those who, not only just those who are married, reported that they experience sexual desire and interest, and none reported engaging in oral or anal sex, and those are the questions that got the most praying going.
So
and
with conservative, you mean intercourse in marriage?
Yes, and this quote maybe reflects it. My religion doesn't allow us to have oral or anal sex, and people do enjoy what God made lawful, such as men and women make love only in the place that God made for them, meaning their vagina. That's how we took that. Okay. All right.
Okay.
Jennifer's going to talk about female genital cutting.
All right, so we did ask about female genital cutting, and our numbers somewhat mirror what the World Health Organization says is happening in Somalia. So 93% said that they had experienced female genital cutting. Only 7% said they had not. And then we asked a little bit of information about what type. We didn't word it that way, but there's the World Health Organization classifies 4 types as being said earlier. And so the type 2 and 3 are more severe. Type 3 is the one, as she said, that includes infibulation. Whereas type 1 is either removal of part of the clitoris, and type 4 is any other. And several women said, I just had what they called Sunni circumcision, which is or Sunnah, sorry, which is just a little kind of ritualistic cut somewhere in their labia. So that, as you can imagine, that's quite different than having your whole vagina kind of reconstructed.
So,
yeah.
So what's the majority here?
So the majority had the more severe type.
The more severe type.
Yeah, and actually if you compare that to what other people say is happening within Somalia, that's a little low. So most women in Somalia are infibulated. And it may be, I've been thinking about this, it may be that some women know what Americans think about female genital cutting and actually downplayed what happened. So we can't be certain because we didn't do examinations. But yeah, so most said that they had a more severe type. We asked, would you circumcise your daughter? And most said no, and they usually followed it up with explanations of the health concerns that they would have. The 2 that did say, yes, I would circumcise my daughter, did not have children. And so I'd be curious to know if they changed their mind after they had kids. And 2 said, I did already, and I regret that. I wish I hadn't. And so kind of related to that, which you'll see in the next slide, we also asked about pain with intercourse, and 40%, we only had 20 because not everybody had intercourse. So out of the 20 people who answered the question, 40% said that they have pain, and 60% said no, which is quite a bit higher than your average population. So if we were to compare that, say, to what's been reported in African-Americans, that's about a 13% rate. So this is quite a bit higher.
This is ever or current?
Current. Well, that's a good question. I don't think it was that clear in the way that the question was worded, whether it was current or ever.
Yeah, that's relevant because in the description of East African pharaonic circumcision that I'm familiar with, the initial penetration in the wedding night with an infibulated organ, which is extremely painful for many people. But then afterwards, once it has broken open and has healed, then afterwards it can be reasonably pain-free. So that's why it's important to know whether it's ever or current.
Right. Well, I don't remember exactly. Do you? I think it was, have you had pain with intercourse? And so yes, I think it could have been more clear of a question. This is actually going to be the area that we focus on in our next study, because that's sort of my area, is the pain with intercourse area, and I ended up frustrated and wanting to know more. So yeah, we could have asked a lot more follow-up questions, actually. And then if we looked at, even just in this small little number of people, if the more severe type was related to pain with intercourse, which there's been many studies that have looked at after female genital cutting if there's pain with intercourse, and there was a meta-analysis done a couple of years ago that said you're 1.5 times more likely to report pain with intercourse if you've had female genital cutting, but nobody's looked at yet at whether or not the type matters. And so this obviously needs to be replicated because this is a very small group. But we have some indication that yes, the type may matter about whether or not you have pain. Okay. So for the thematic analysis, there was a question that asked basically what, how do women express sexuality in your culture? And so a lot of the analysis came from that question, but I also looked at the transcript as a whole to kind of see what can we learn from the way that people are talking during the interview. And so here's a few of those themes that sort of came up spontaneously. So as being said, many women talked about, well, we are Islamic people, and so therefore we're not at risk for HIV. And so that was one of the things that was said many times by different women. And in a way, if you look at Somalia's rates compared to other rates of countries nearby, they're right. They do have lower rates. So, but we'll talk a little bit about, how that kind of puts them at risk as well to have this belief, because as you all know, a virus doesn't care what religion you are. And so also, as we mentioned, there was women that talked about, yes, I have desire and I'm interested in sexual relations with my husband. That's, dictated. The Quran talks about that, and the Quran also talks about that, it's important that he makes sure that I am happy. So it's not only about his satisfaction. Overwhelmingly throughout the interview, women talked about privacy and how it's really quite inappropriate to talk about sex with your friends, your mother, your children. It's almost shocking that we got women to talk to us because they constantly would say things to the effect of, sometimes if we'd ask a question to the effect of, do Somali women use condoms? And they'd say, I don't know. I don't talk to my friends about whether or not they use condoms. So there was just sort of this constant mention of privacy. And there was also, and this is in part, I think, because of the questions we were asking, but when we asked, how do women express sexuality in your culture, they would pointedly say, there is only one appropriate way. And Sophie read that quote. I think the reason we assumed it was the vagina that woman was talking about is because another woman said, God made this hole for a reason. And so there was sort of, this is the one way. And then talked about other things as well, no infidelity, no premarital sex, and even no sexual contact during courtship. We asked specifically about, in the context of HIV, do you have the right to tell your partner that you do not want sexual activity? And one of our concerns, based on what we heard from our community partners, was that women may be pressured, even if they thought their husband was unfaithful, that they wouldn't have the right to say no, and not know, and not be able to ask him to use a condom. And so almost all the women did say, married and single, said, yes, you have the right to tell your partner what you want to do if you're too tired. I do think this was somewhat skewed because of our questions about oral sex and anal intercourse, because I think that was on the women's minds. And so I think asking then, do you have the right to say no? They're like, yes, I have the right to say that I will not do those things. And one woman even said, if that is why I'm divorced, because he asked, and then that's okay. That means automatically we get divorced. So, and there were only 3 women that said, no, it is a sin to refuse your husband. But what's interesting is that they also, all 3 of those women also said, but if he asks me for something that is not religiously appropriate, I can say no to that. So there was a little bit of a discrepancy there. All right, so one of the things that was the most interesting to me was how hard it is to train somebody to do an interview. And so our interview did a wonderful job, but, oh, I'm skipping ahead actually. But there are many questions that she didn't ask, and sometimes I think it was because she was reading their nonverbals of, I've had enough, you don't go farther into this line of inquiry. But other times we weren't exactly sure if it was her experience level with interviewing. So those are some of the reasons that we have some missing data. And we also have some missing data just because there were several women that had never been in a sexual relationship. So in the future, we're going to ask for only people who have. And then, as I said, some of the information was a little unclear because I think Fatah was trying to be very careful about asking systematically, and then didn't always ask for clarification if there was some contradictory information.
You just hand these out.
Sure.
So I have about 10 of these. These are the community reports that we prepared because we, we're doing it with our advisory group and with community participation. We felt a responsibility to bring back our research results to the community. And I've done this before when I've worked with other minority communities. So we hired a local artist to develop the artwork for us. And you'll see inside, there we go. We just have 2 pages where we try to make the results kind of highlights, very simple. We tried to make it fun with pictures and colors. The artist did this for us. And we had 2 pages in English and then 2 pages in Somali. We held a community research presentation meeting and invited members of the community. We got pretty good participation. We got 50 people to come, and it was quite spirited. And it's interesting, Somali men and women, when they're together in a room, they just kind of like talk and yell at each other. It's very exciting. It's a fun group. And it's funny, I work in one of our residency clinics deals with a large Somali population, and one of our residency medical clinics deals with a Hmong population. And the Hmong population, they sit very quietly in the lobby, and it's very silent. Then you go in the Somali waiting room, and there's all this talking and milling around and socializing. So, you know, again, it's just different cultural differences. Okay, so some of our...
Which language is this?
Somali.
That's not the form of Arabic.
No.
It's a mix of so many languages. It's a mix even parts of Swahili, reading the languages, also so many.
They didn't have. There wasn't a written language until the 70s, and so yeah, even Italian, because Somalia was occupied by the Italians for a while. So there's. Yeah.
It's a mix.
So to sum up, we found that the HIV testing rate was high, but maybe it's lower for those born in the U.S. since so many were tested during immigration. So people who were born here, maybe that rate's not going to be so high, so we shouldn't take it for granted. Condoms are acceptable for many, and any intervention should definitely consider education about condoms, but have to consider the culture's privacy rules around sexuality. Pain with intercourse seemed to be higher in our sample, and that may be due to female genital cutting, but that's what we're going to pursue in our next study. Conservative sexual beliefs and values encourage low-risk behavior, but providers need to bring up these sexual topics to give permission for those women who are willing to talk about sex and HIV. And here's the paradox. You know, they assume they're not at risk because of religious beliefs, and that is true. There are some studies which show that countries with large Muslim populations have lower HIV rates because of those conservative sexual values. For instance, Gray in 2004 found that the percentage of Muslims in 38 sub-Saharan African countries negatively predicted HIV prevalence. So there's some truth to that. On the other hand, if you think you're immune, you know, that is itself is dangerous because you don't do what you need to do to keep that immunity up.
Oh.
Okay, so we just want to mention some of the limitations. So obviously the small sample size, we had a small pot of money, and we did what we could. And so we are going after a larger grant so that we can follow up and look at some of the inconsistencies and generalize better. So this is probably limited to a unique group of women that were okay, somewhat okay, talking about sexuality with a stranger. And so they may actually have, we don't know, but maybe more progressive attitudes than some of the other women. And so one of the things that we've learned from our community partners is that the women in Minnesota are actually a little more conservative than Somali women living in other states, because there's such a large population that it's a culture that sort of keeps to itself, you know? And so like Amira was telling me this story about how, you know, she learned essentially from us about oral sex, and then she was talking to one of her cousins in Virginia who was like, well, yeah, everyone has oral sex. And so it was
those Virginians.
Those Virginians. So
crazy.
She was saying, you know, we as a culture sort of, you know, have a big boundary around ourselves in Minnesota. And so that, you know, some of our findings might not generalize beyond. Everyone was heterosexual, or at least said that they were, and there's a huge, we have a whole other, some questions about attitudes towards sexual orientation, and it would be very difficult for someone to say that they were not heterosexual, but everyone said they were. This was, for both of us, this was a new experience to conduct a study in a different language, and so it's a little disconcerting in some ways because you don't know for certain that concepts are translated in a way that is appropriate. And so, you know, it's possible that some language or conceptual barriers may have influenced participants' understanding and their answers. Oh, and so the example of that we haven't mentioned is our advisory board said, men on our advisory board said, do not bother asking women if they have orgasms, they will not understand. And then all the women got very offended. And so every Somali woman that worked on our project wanted to translate orgasm differently. And the person that had the longest explanation was 64 words. And when we read the data, we thought, I don't know if this is, we're really unclear whether or not people were following one another, if Fatah and the participant was following one another when discussing orgasms. And so we ended up throwing all of that out. So that's just one example, and one of the more interesting ones, of how the language barrier was a problem at times. And of course, like many studies, we don't know how much social desirability influenced the answers. Participants were given a choice of having an American interview them or a Somali-born woman interview them. And everyone chose the Somali-born woman. But again, because they were from the same culture, there may be times where people, didn't feel comfortable endorsing something that would be a little different or not acceptable in their culture. Okay. And as I mentioned before, she didn't always probe for clarification as we would have liked. We had 4 funders, with most of the money coming from UCARE, and the rest gave us small amounts that helped fund the study. And here's our references. The advisory board was interesting because not everyone said it was okay to take their picture and put it on our website. So we have some pictures, and then this is the group that advised us on many steps of the study. And here's some pictures of our meetings.
And just other acknowledgments. I just want to call out especially our the professional interpreting service we use. Were actually interpreters who interpreted for medical appointments, so they had never really done anything like this before, but they were willing to give us a pretty good rate because of the number of interviews, and they were willing to kind of change what they usually do to do this. So if you were going to do a study, you know, it's not like there's somebody out there who does this. You might have to find somebody and have them modify what they do. I think that's it. That's our contact information.
We are done.